My name is Dr. Landreth. I am a second-year radiology resident at the Oregon Health and Science University in Portland, Oregon. In this month's submission, the reader will find literature reviews for both cardiac and thoracic imaging. Topics reviewed include quantitative CT imaging of COPD and fibrotic lung disease, pulmonary embolus and its association with the novel coronavirus, an analysis of the RSNA chest CT classification system for COVID-19 and its relation with real-time PCR results, the feasibility of 4D flow MRI in healthy patients, the added value of AI CT fractional flow reserve in TRO scans, and AI-driven true and false-Lumen segmentation of aortic dissections. Before we get fully started, I would like to give a special thanks to my senior editors for this month's publication, Dr. Christina Foos from Oregon Health and Science University, and Dr. Prasad Pants from the Mayo Clinic. Without their help, this blog would not be possible. In this article, published in the Journal of Thoracic Radiology, researchers from St. Paul's Hospital and University of British Columbia report interesting applications for the quantitative CT in the realm of chronic obstructive lung disease and interstitial lung disease. Researchers pose that quantitative CT applications can be used in adjunct to typical qualitative assessments of COPD and ILD to diagnose and track progression of these two complex disease patterns. Quantitative CT can be used in COPD to accurately map areas of emphysema, identify airway thickening, and create 3D reconstructions of the bronchial tree to identify early disease of the terminal bronchioles. Major limitations in the clinical application of quantitative CT in COPD are the exposure to high amounts of ionizing radiation, CT scanner and patient variability, and significant quality control due to the need for manual post-processing by a qualified radiologist. Quantitative CT can play an important role in tracking the progression of interstitial lung disease by examining discrete pulmonary parenchymal densities and plotting these findings on a density histogram. This objective data could be used in conjunction with qualitative evaluations to provide clinicians with a more precise way to track disease progression and treatment response in a highly morbid patient population. Significant improvements are still needed in these quantitative algorithms before they find surefire clinical applications, but these are exciting developments nonetheless. Published in the Cardiothoracic section of Radiology, Italian radiologists provide a window into the association of the novel coronavirus and thromboembolism in severely ill patients. COVID-19 patients are noted to have a higher rate of pulmonary arterial emboli, which is especially concerning given the higher frequency of critically ill patients at baseline. In this retrospective study, 109 patients with COVID-19 who exhibited symptoms concerning for pulmonary embolus who had a CT pulmonary angiogram to rule out pulmonary embolus were enrolled. Patients were assigned a semi-quantitative score, 0 to 5, to estimate pulmonary involvement of the 5 lobes of the lung. Patients with higher CT lesion scores and abnormal lab values, such as lactate dehydrogenase and elevated CRP and D-dimer, were found to have higher rates of pulmonary thromboembolism. These hypercoagulable phenomena preferentially involved the segmental and subsegmental arteries of the pulmonary parenchyma, which were most affected by COVID. The authors postulate that these are pulmonary artery thromboses secondary to local lung inflammation and hypercoagulable state rather than emboli. Although the study lacks the power to definitively verify this statement, the authors draw upon evidence from other studies that further justify their claim. Hopefully, future studies with more data points will be available to validate their hypothesis. In another article published in the Cardiothoracic section of Radiology, researchers from the Zuiderland Medical Center in the Netherlands investigated the RSNA chest CT classification system for reporting COVID-19 and the COVID-19 reporting and data system, also known as CORADS, for Interobserver variability and for their findings association to patients' real-time PCR results. Researchers found substantial Interobserver agreement between radiologists in their stratification of patients. An overwhelming number of patients who were categorized as having typical COVID-19 findings had positive PCR results. However, a non-negligible number of patients, on the realm of 20 to 25%, who were assigned as having negative findings associated with COVID-19, unfortunately had positive PCR results. Researchers suggest that this cohort who were assigned as negative may have been at a different stage of disease and thus presented to the hospital at a different time frame. However, this result seems to mimic real-life practice. It seems as though CT may not be a viable role as a screening tool for COVID-19. CT is still an important part of patient care, given COVID-19 patients can be a highly morbid and mortal group. In an article published in the Cardiothoracic section of Radiology, researchers examined the effectiveness of free-breathing 4D flow MRI during exercise in a healthy cohort of 10 individuals. This cardiac MRI protocol was performed at rest and during stress, in which a standardized exercise protocol was implemented on an MRI-compatible stair-stepper device while supine in the bore of the magnet. These studies were retrospectively gated to account for breath motion artifacts and EKG gated to account for cardiac motion. This group used a 4D flow protocol to assess stroke volume and ventricular kinetic energy in both systole and in diastole during both rest and exercise examinations. They found that cardiac output predictably increased during exercise when compared to examination at rest. Interestingly, the researchers observed the right ventricular kinetic energy was significantly increased in systole when compared to rest, while the left ventricular kinetic energy and stroke volume were not. Stroke volume had previously been documented to be unaffected during supine exercise, so this was an expected result. The kinetic energy of the right ventricle was noted to increase in systole when compared to the left ventricular kinetic energy. Left kinetic energy was not significantly increased during exercise, thus limiting the application of 4D stress MRI for left-sided pathology. However, this new test may become a valuable tool for the evaluation of right heart disease. There are still some notable limitations for clinical application as current practices stand. These are secondary to subjective assessment, which leads to poor interobserver and interobserver reproducibility in relation to both ventricular masking and kinetic energy estimation. Radiologists at the Medical University of South Carolina describe an application for machine learning in estimating fractional flow reserve during triple rule-out CT angiography. In a retrospective review encompassing 159 patient examinations, researchers reviewed 159 triple rule-out CT angiograms, or TROs, for patients who had low to moderate probability risk of cardiac disease. The fractional flow reserve was then calculated using a deep learning algorithm, which is not commercially available. The fractional flow reserve exhibits high diagnostic accuracy in evaluating significant obstructive coronary disease and has been used in the ambulatory setting to assess coronary artery disease. This group sought to use this FFR calculation in the emergency setting to identify patients with hemodynamically significant stenoses and used coronary intervention or major adverse cardiovascular events, otherwise known as MACE events, as endpoints. A fractional flow reserve less than 0.8 was considered hemodynamically significant stenosis. Of the patients who received a TRO, 55% had significant stenoses and 5% had severe stenoses, which were greater than 70%. 52% of the study subjects exhibited congruent findings in both fractional flow reserve and TRO. Of these, 55% were found to have significant coronary stenosis and an FFR less than 0.8, while 45% had an FFR of 0.8 and no significant stenosis on TRO. In chart review, it was noted that coronary revascularization, or significant MACE events, occurred in 27.5% of patients imaged, and that those with an FFR of less than 0.8 were significantly more likely to meet one of the two endpoints than their peers. It is also noted that 67% of patients who received a TRO underwent further downstream testing, a relative common phenomenon. The authors posed that an FFR of less than 0.8 may be useful to delineate patients who are at increased risk and would warrant further testing. It is noted that 4 patients who had an FFR of greater than 0.8 underwent coronary revascularization. So these 4 patients may have missed out on therapeutic intervention had an FFR less than 0.8 been used as a cutoff value for further referral. It is also noted that in 54% of patients who underwent both TRO and SPECT, and 48% of patients who underwent TRO and stress echocardiography, there were discordant findings. 3 of these patients had an FFR of greater than 0.8 and a positive result on stress SPECT CT. As this study was retrospective and no treatment decisions were made using the FFR cutoff of less than 0.8, it is unclear how many patients would ultimately have a negative outcome. It seems, however, that adding an FFR to TRO patients with low to moderate risk coronary artery disease may be a valuable addition to the assessment of emergent acute chest pain. Researchers at Stanford utilized this stepwise convoluted neural network to automatically generate multiplanar reconstructions of uncomplicated type B aortic dissections, and then to segment the true lumen and false lumens. Researchers retrospectively identified 45 patients with a cumulative 153 CT angiograms of the aorta, or CTAs. Patients were randomly assigned to a training set, a validation set, and a test set of studies, which were then fed into the convoluted neural network's stepwise segmentation algorithm. The steps for segmentation included first identifying the aorta from background in the axial plane, determining the aortic center line by utilizing the average density within the aorta, generating MPRs, or multiplanar reformats, in an orthogonal plane from the center line, then segmenting the aortic dissection into both true and false lumens. Finally, the algorithm converted the multiplanar reformats back to the axial plane. The automatic segmentation was compared to internal controls, which was the test set, and to manual aortic segmentation by expert cardiothoracic radiologists. Endpoints for this study included the dissimilarity coefficient and the average Euclidean distance between edges in millimeters. Researchers found that there was no significant difference between the validation set and the test set of data, with an average segmentation coefficient ranging from 0.873 to 0.9, suggesting a highly accurate segmentation process. The average Euclidean distance was less than 3 millimeters, and automated segmentation also generated diameter plots for the true lumen, false lumen, and aorta throughout its length, giving radiologists the ability to quantitatively assess volumes of the aortic dissection. This is highly applicable to patient care in that aortic diameter is used to triage aortic intervention. Current clinical applications are still somewhat far off, given the need for manual input by an expert user, as errors can occur in the identification of the true lumen and false lumen, reported in an average of less than 4% of studies. The authors also propose that the convoluted neural network may have been introduced into bias, since the same study population was used in both testing and in validation. As datasets and patient population grows, the convoluted neural network should be able to differentiate a wider phenotypic variety of dissections, and most AI algorithms tend to struggle in real-life scenarios due to the innate variability in CT scanners, patient body habitus, anatomy, and inherent noise in scans. As AI continues to improve, this will undoubtedly become a reliable tool for clinicians to monitor uncomplicated type B aortic dissections. I would like to thank you for joining me for this month's iteration of the Academy of Online Radiology Education. See you next month.